Good afternoon, everybody. I'm Dr. RUCHI Agarwal, Junior Resident at King George's Medical University, Lucknow, and I'm presenting my paper on randomized control trial for comparing conventional versus wide-angle non-contact viewing system for scleral buckling surgery. I do not have any financial disclosure or conflict of interest. The management of retinal detachment. The goal is to seal the tear to prevent further fluid from entering the subretinal space and to relieve the vitreous traction. Basic principle for any surgery, whether it be pars plana vitrectomy, scleral buckle, or pneumatic retinopexy, is identification of the retinal breaks, induction of aseptic chorioretinal inflammation to create a seal, and the chorioretinal apposition via external or internal tamponade. The scleral buckling surgery aims to indent the sclera and choroid by providing an external tamponade that brings the retinal break closer to the retinal pigment epithelium and displaces the subretinal fluid away from the tear, thus facilitating the reattachment of the detached retina. The commonly used illumination and viewing system has been the indirect ophthalmoscope with a plus 20 diopter or a plus 30 diopter condensing lens. Here we are comparing it with this new endo-illumination system via a chandelier inserted through pars plana in combination with the wide-angle intraoperative viewing system. The aim of my study is to evaluate the results of treatment of rhegmatogenous retinal detachment surgery using a non-contact wide-angle viewing system and comparing it with the traditional scleral buckling surgery using an indirect ophthalmoscope. There have been multiple studies done, but the limitations are that these studies have been retrospective with a smaller sample size. There has been a lack of comparison group, and they have not been done in Indian population. So the study design is a randomized single-blind control trial at a tertiary care center in northern India. The patients diagnosed with rhegmatogenous retinal detachment with PVR less than grade C were included, and the intervention given was scleral buckling surgery using wide-angle non-contact viewing system with chandelier illuminator. The comparison group were the patients undergoing surgery with an indirect ophthalmoscope. The outcomes measured were primary outcome was anatomical reattachment of retina. Secondary outcomes were improvement in BCVA and per and post-operative complications at day 1, 7, 30 and day 90. The selection criteria were patients presenting with rhegmatogenous retinal detachment, eligible for scleral buckling surgery and ready to be followed up for 3 months. Patients with deep set eyes and post-glaucoma patients were excluded. This was a randomized control trial and CTRI registration was done. A concert 2010 flow diagram was followed and 46 patients were included, divided into 2 groups. Group A with the newer technique consisting of 23 patients, and Group B with the conventional scleral buckling with 23 patients. The descriptive stats was analyzed and the statistical analysis was done using MedCalc software, and the categorical data was represented in frequency and proportion and continuous variables by count, mean, standard deviation, median and minimum maximum. The descriptive stats were comparable between 2 groups. The operating time was evaluated, and the arithmetic mean in Group A was 122 minutes, while in Group B was 111 minutes, and this was significantly higher in Group A. The primary outcome, that was reattachment of retina, was evaluated by chi-square test, and the difference was not statistically significant between 2 groups. Similarly, the change in BCVA was not significant between the 2 groups. These are the per-op complications. Subretinal bleed was present in 2 patients in both the groups, and in Group A, additional complications due to shifting of the chandelier, lens touch causing cataract and vitreous incarceration at the post site were seen. Post-op complications between the 2 groups were similar. There were media haze due to subretinal bleed and unattached retina in 1 patient in both the groups. So previous studies have been done. In 1980s, Bonnet M used a operating microscope with slit lamp illumination with a Goldman 3 mirror lens to visualize. And in 2004, OG, M and Tano Y used a surgical microscope with a slit lamp illumination and wide field contact lens to perform scleral buckling surgery. Optic fiber-free intravitreal surgical system was used by RUCHI et al. And RS et al. Did a similar surgery to performed a similar study to ours, but a torpedo-based light source was used in their study. In our study, these are the advantages and disadvantages that we experienced. The insertion of chandelier illuminator was via a trocar and cannula and a small port size. It was easy to adjust, change, and the site had need not be closed with a suture. A wide field of view was seen, and adjustable magnification was provided by the slit lamp. Comparable rates of attachment and post-op BCVA was seen as with indirect ophthalmoscope. It acts as a good teaching tool because the surgery can be demonstrated, unlike that with indirect ophthalmoscope. and better ergonomics were seen. Disadvantages were intraocular entry, poor view in hazy media, increased operating time due to lack of experience and need to change the position. The limitations of my study was small sample size and learning curve. The chandelier illuminating assisted scleral buckling surgery thus yielded comparable results and can be used for the rhegmatogenous retinal detachment, and it yielded good results compared with the traditional scleral buckling surgery.